Our final speaker has the unenviable task of trying to tell us management of herpes in pregnancy in 10 minutes. Welcome Associate Professor Cheryl Jones from Westmead, and who has done a lot of work on neonatal herpes and herpes in pregnancy. Thank you, Cheryl.
Thank you. Firstly, I'd just like to acknowledge Suzanne, who has generously given me a lot of her slides from her presentation about the same topic yesterday. The reason that herpes in pregnancy is such a difficult thing to manage is because of the rare but devastating complication of transmission to the newborn. The public health problem with this is that because HSV, genital HSV, is often asymptomatic, most women are unaware of their diagnosis of genital HSV until they have an infected infant. What are the risk factors for the mother passing the infection across to the baby? By far the greatest risk factor is if mum is having her first genital HSV infection during pregnancy. Another important risk factor is if she is HSV seronegative to an HSV type that her partner has genital herpes with. If mum has herpes and has virus in the genital tract, performance of an invasive obstetric procedure, such as those listed here, increases the risk of transmission. And if she has genital herpes but is not seroconverted well, then that's also a significant risk. So what are these risks? Most of this work comes from very large studies performed by Zane Brown and others in the Seattle group in Washington. If mum is having her first genital herpes, the risk of transmitting the infection across the newborn is up to 50%, and some would even say higher. But what of all these women who have a known history of genital herpes? Of those, only 1% will be shedding the virus in the genital tract at the time of delivery. And that group have a slightly high risk, but it's significant, of about 3 and possibly up to 5% transmission. However, for the bulk of the women who have no shedding and no symptoms, the risk is very, very low, less than 1%. Another important thing about women who are having their first attack, if they have seroconverted well before the onset of labour, that risk is now down to a lower group, down to about the 3 to 5%. And that has important management implications. So what are the ways we can reduce transmission to the newborn? Antenatal screening, the use of predictive antenatal cultures, is not useful, and work of Sue Garland and others have shown that it doesn't help us in determining which women will have virus in the genital tract at the time of delivery. The topic of should we be performing routine type-specific HSV serology antenatally. In Australia, we're not currently recommending that. There may be individuals that it's worthwhile doing that in, and I won't discuss that further. Barrier methods actually, sorry, that isn't to say not recommended, that is recommended. That shouldn't say that there. There's good data that barrier methods certainly can reduce transmission. We don't know any data about affecting transmission to the newborn. I'll talk about suppressive therapy and C-section in a minute, but for all of these women, whether you're having your primary genital herpes or a history of past herpes, if they're having a vaginal delivery, they should reduce invasive monitoring. And we know that in the future, we've currently got a vaccine to prevent genital herpes in women who are seronegative. This will help us potentially in the future. So what about antiviral therapy in pregnancy? As you know, it's a Category B drug, but there's a very large registry in America which is indicating that it's generally had no adverse fetal effects. A number of people have looked at the pharmacodynamics of acyclovir in pregnancy. It does get concentrated in the amniotic fluid, but there's been no adverse effects in either the fetus or the newborn at delivery or at follow-up. So in general, we would recommend treating with acyclovir for a woman who's having, during pregnancy, her first episode. That should be IV if she has disseminated HSV. You would treat a woman with symptomatic recurrences as you would with any of your genital herpes patients. But arguably, a woman who's having frequent symptomatic recurrences, we would recommend giving suppressive acyclovir from 36 weeks on to reduce the risk of having lesions at the time of delivery, which would indicate performance of an abdominal delivery. Valacyclovir hasn't itself had published studies in pregnancy, but as you know, Larry Corrie's group from Seattle have recently shown that the use of valacyclovir in partners with discordant partners reduces the risk of transmission. This is non-pregnant individuals to their partner and also reduces asymptomatic shedding. So again, this will have a potential role in suppressive recurrences and potentially suppressing transmission to the newborn. One of the difficulties of any of the studies using antivirals in pregnancy is that the complication of neonatal herpes is so uncommon that you can't use that as an outcome measure. You just can't possibly design a study that's that big. C-section to prevent transmission. For the first time, Zane Brown again in 2003 has shown us that if a woman has virus in the genital tract at the time of delivery, there is reduction of the risk of transmission to the newborn. Now, to point out, this study was not a controlled trial. What they did was look at a prospective cohort. So there are many biases that were in this study. The point of this is not that all women with genital herpes have a C-section. In fact, far from it. It's those with primary genital herpes where we know there's a strong risk of virus in the genital tract or potentially frequent symptomatic recurrences. So again, this is only supporting for a subpopulation of women. Another important fact is that if the women have prolonged rupture of membranes beyond 6 hours, there is no protective effect. And in our own surveillance of the infants who have neonatal HSV disease in Australia, we still know about 30% of them are born to women who've had C-section, and some of them reportedly born to women who've had intact abdominal membranes. Whether that's hindwater leak, viremia, we don't know. The point I'm saying is it's not completely protective.